So a very good evening to everyone present here. Welcome back to the ISN Journal Club. We didn't have it last month because of the ISN WCN meet which we had. So this month, we are going to discuss about efficacy and safety of obinutuzumab in active lupus nephritis. The presenter will be Dr. Nitin Koshi from Amrita Hospital, Kochi. We have esteemed panelists with us, Dr. Manish Rathi sir, Professor of Nephrology from PJMR, Chandigarh, who has worked extensively in lupus nephritis, and Dr. Mayuri Triwari ma'am, Senior Consultant and Head from Lokmanya Tilak Medical College uh, from Sion, Mumbai. So welcome. Back to Nitin Koshi for starting the presentation. Any queries, please post in the chat box. We'll take it up for discussion after the presentation. Thank you. Nitin, you can start.
A very good evening to all the moderators, panelists, and my colleagues and my teachers. I thank ISN for this opportunity to present this journal club today. So today we'll be discussing about the efficacy and safety of obinutuzumab in active lupus nephritis. This came out in the journal, New England Journal for Medicine in February this year. So this is a phase three trial which had been published. The background. Lupus nephritis is a formidable manifestation of SLE. 60% of the patients of SLE have lupus nephritis. So as we all know, it is the leading cause of kidney failure in young individuals worldwide. Pathogenic B cells are the ones which produce these autoantibodies, which leads to lupus nephritis. In short about the treatment, when there is activity, we start with immunosuppressants. Chronic cases do not really need an immunosuppression, but if there are other manifestations, like the extrarenal manifestations of SLE, then immunosuppression is given. For the ones with chronic disease, we usually give supportive therapy for CKD as is usually indicated. So this is just a image showing the treatment of lupus nephritis, class 1, class 2, class 3. Kidney protective measures including blood pressure control, RAS blockade, immunomodulation with HCQ is given. When there is active lupus nephritis, we prefer steroids along with mycophenolic acid or cyclophosphamide also. When the disease is further difficult to treat, we also add other agents like rituximab, tacrolimus, or belimumab also. These are newer agents which have come up. There are multiple studies which are going on regarding these new agents, and they are found to be beneficial in the treatment of lupus nephritis. These are just a few studies which have recently been done. The LUNAR study, wherein rituximab was added on to the usual standard of care therapy. Here, it was found that because of B cell depletion by rituximab itself, there was a benefit in treating patients with lupus nephritis. But however, the overall benefit was not really ascertained in this study. So there started this B cell depletion therapy, which could actually help more in lupus nephritis. Then the Regency trial came up where the second type 2 B cell depleter came in, and that is obinutuzumab. So this is the probably the pillar to which this nobility trial came up. Here it was detected that this drug is beneficial in lupus nephritis, and there was a significant benefit which had to be studied upon, and the safety of this drug had to be studied upon, and then nobility came up. Which is the trial which we are going to discuss today. Bliss LN trial is belimumab, which is added on to the standard therapy of lupus nephritis, and that was also found to be beneficial. Calibrate trial was cyclophosphamide plus rituximab, followed by belimumab on top of cyclophosphamide in resistant cases of lupus nephritis. The drug obinutuzumab, it's actually a humanized glycoengineered type 2 anti-CD20 monoclonal antibody that has been approved for treatment for CLL and follicular lymphoma. So there, the B cells were depleted much better when compared to rituximab, and hence this drug was used for its treatment. The anti-CD CD20 therapy, there are two types, which is type 1 and type 2. Type 1 is our rituximab, which we previously were using. They deplete the B cells via the complement-dependent cytotoxicity, antibody-dependent cellular cytotoxicity, but then the depletion is incomplete. So there are some B cells which are left behind, which will be resistant to this therapy. Whereas the type 2 anti-CD20 monoclonal antibodies have stronger B cell cytotoxicity and enhanced phagocytosis, profound and sustained depletion of the tissue residual B cells as well, which helps us get a better response. And also, the risk here is the infections which are associated. So the trial which is to be discussed today, the Nobility trial, here we have compared obinutuzumab plus standard therapy, which is mycophenolate and glucocorticoids, with a placebo drug and standard therapy. So the improvements in patients were assessed at 52 weeks, 76 weeks, and 104 weeks when compared to the placebo. So the reason why it was undertaken was there was a noticed delayed progression of lupus nephritis, as well as a decrease in the decline of GFR when compared to placebo. The design of the study, it's a phase 3 randomized double-blind placebo-controlled trial across 15 countries. Inclusion criteria which was used for this study was people of 18 to 75 years of age with a biopsy confirmed active lupus nephritis, which is either class 3 or class 4. Class 5 also may be included, which was done on screening or within 6 months of the screening. Urinary PCR of more than 1 gram and a positive ANA. The exclusion criteria, wherein the GFR was less than 30 patients were excluded, active infection patients were excluded, recent anti-CD20 therapy, and that was with either rituximab or any other drug which would reduce anti-CD20 was also taken off from the patient pool. And recent immunosuppressive therapy other than this anti-CD20 therapy also were excluded, including patients who were previously on probably cyclophosphamide and tacrolimus for the treatment, other than the standard of care. Uh, so 513 patients were assessed from July 2020 to March 2023. So according to the exclusion criteria, there were 242 excluded, and randomization was done in 271 patients, out of which 135 were in the obinutuzumab group. So here again in this group, there were two subgroups which are created, wherein there was a 2-2-2 regimen, which I'll be talking later about, and a 2-2-1 regimen, 69 in one and 66 in the other group. So when 76 weeks were completed, the total number of patients who completed the study were 122. Withdrawal of patients and a few deaths had occurred during this period, and that is why it had reduced. In the placebo group, however, there were 136 patients, out of which there were 16 patients who had left the study, and the rest of them had completed the study. Around 120 patients had completed the study. The baseline characteristics of the patients, some of them which I would like to point here are the age. 33 years of age was almost the average in both the groups. Female sex was predominant in both groups, wherein there were 84 percentage 84 percentage females in one, and the placebo group also had similar 84 percentage females. Males were underrepresented, probably because the prevalence of lupus is like that too. And our population, Asian population, there were only 9 in the obinutuzumab group as well as 7 in the placebo group. Whites were the majority, wherein 65 in the obinutuzumab group when compared to 64 in the placebo group. Other characteristics, median serum creatinine level of 0.7 was almost similar in both groups. GFR was similar in both groups, but if you see the proteinuria, in the placebo group, that was mildly higher than the proteinuria in the obinutuzumab group. Complement C3 levels were almost similar. Other characteristics, again, if you see less than 3 gram proteinuria, there were 82 in obinutuzumab when compared to 74, and more than 3 gram was 62 in the placebo group when compared to the obinutuzumab group. Um, Baseline lupus nephritis concomitant class 5 was 47 in obinutuzumab group and 38 in the placebo group. Prior history of lupus nephritis was more in the obinutuzumab group, which was around 81 when compared to the placebo group, wherein it was 76. The intervention in the study. So the patients were randomized and two groups were created. And in the obinutuzumab group itself, there was two separate groups created, wherein one received the 2-2-2 regimen, the others the 2-2-1 regimen. So the 2-2-2 regimen here is the drug which was given at 0 weeks followed by 2 weeks, then 24 weeks, and then 26 weeks, followed by 50 and 52nd in the 2-2-2 group, whereas the 50th week dose was skipped in the 2-2-1 uh, regimen. At 76 weeks, the results were actually observed. Uh, on checking if there was any improvement at all, if there was improvement in the patients, then they were continued in the blinded treatment continuation limb here. And if not, then open label treatment was initiated henceforth. So every 6 months, there was a follow-up after that. The target dose of MMF, that is the standard of care, was around 2 to 2.5 grams per day. IVMP was given at 250 to 1000 mg prior to the first infusion itself, followed by prednisolone at 0.5 mg per kg, and then it was later tapered down in a weekly manner to reach at least 5 mg per day by week 24. And then it was maintained at that dose. The endpoints or outcomes, primary endpoint here was complete renal response, also known as CRR, at week 76, which is defined by a proteinuria of less than 0.5, GFR of more than 85% of the baseline, and no intercurrent events, including rescue therapy, treatment failure, death, or an early trial withdrawal. Uh, Although it says excluding rescue therapy with small dose of glucocorticoids were permitted in the study, but other rescue therapy was excluded. Secondary outcomes. So multiple other secondary outcomes were studied upon. One was the proteinuric response at week 76. So wherein UPCR of less than 0.8 was defined as a proteinuric response without any intercurrent events. Proportion of patients who achieved CRR with successful prednisolone taper also was taken as a secondary outcome, wherein prednisolone was less than 0.75 by week 64 to 76. Overall renal response, wherein both our complete renal response as well as the partial renal response was taken into consideration by week 50. So partial renal response is another term which was defined here, wherein more than 50% reduction of UPCR from baseline was one of the points. The other was UPCR of less than 1 gram or less than 3 gram if the proteinuria at baseline was more than 3 gram. And a GFR of more than 85% of baseline, which is similar to that of the complete renal response, and no occurrence of any intercurrent events. Proportion of the patients who experienced death or renal related events through week 76, which included death, treatment failure, worsening proteinuria, or worsening EGFR. So worsening proteinuria was defined by more than 50% increase in proteinuria, and worsening GFR was defined by more than 30% decrease in GFR to a level of less than 60. Another interesting point here was there was a FACIT F score, which is Functional Assessment of Chronic Illness Therapy Fatigue Scale, wherein a questionnaire was given to patient to assess the level of fatigue among the patients who took part in the study. Other supportive endpoints was the anti-dsDNA levels, the C3 levels and C4 levels at week 50. Results of the study. So primary endpoint was complete renal response. If we see, there was 46% in the obinutuzumab group when compared to 33 in the placebo group, with a p-value of 0.02, which is clinically significant. Secondary endpoints also, we can see that prednisolone taper could be achieved better in the obinutuzumab group, wherein 42% had a taper which was possible to less than 7.5 mg when compared to the placebo group, which had 30% with a p-value of 0.04. The proteinuria reduction also had significant reduction, wherein 55% had proteinuria reduction to less than 0.8 and 51% in the placebo group with significant p-value. The other thing which I would put on is the overall renal response at week 50, wherein partial and complete is taken into consideration, which was almost around 60, which is 59% in the obinutuzumab group and 50% in the placebo group. However, the p-value was not really significant. Intercurrent events that occurred during the study. Uh, so patients with more than one intercurrent events, there were 15 in number, majority of which was treatment failure or worsening UPCR in the obinutuzumab group, which was 5 each in number. In the placebo group, there were 34 intercurrent events, wherein treatment failure was more of around 24 in number, and worsening urinary protein was 22 in number. Rescue therapy in the total group was 8 in obinutuzumab group, and placebo group required 24 patients who had rescue therapy taken. Glucocorticoid only rescue therapy was actually considered okay in the study, and that was 5 in obinutuzumab group and 11 in the placebo group. Death was 3 in obinutuzumab group and 1 in the placebo group. I'll come to the recent cause of death of these patients later. Loss to follow-up were none, and withdrawal of the patients, 6 withdrew from the obinutuzumab group and 5 from the placebo group. The withdrawal of patient or incomplete were taken as no lack of response itself in the study. So a few graphs showing the variations of different parameters here, wherein C3 levels were significantly better when compared to the placebo group. C4 levels also were better in the placebo group, in the obinutuzumab group when compared to the placebo group. dsDNA levels were lower in the obinutuzumab group when compared to the placebo group, and B cell depletion was, as the drug is used for, is better in the obinutuzumab group. Statistics. So here 90% power to detect the difference between the group, whereby at least 20% points was taken, so that a significant level of 0.05 was present. So as we can see, this is the baseline, and 20% towards the placebo and 20% towards the obinutuzumab group. Among all patients, 46 had complete renal response, and so that was 20%, almost near 20% better than it was 13% better than the placebo group. Almost all the limbs showed a betterment towards the obinutuzumab group, except for this male sex ratio, wherein only 21 patients were enrolled in both the groups, and probably that is why we really do not have much information in the study about the male lupus nephritis cases. Other geographic region is where we belong, and in the other geographic region also, the data shows that obinutuzumab had shown to be a better drug when compared to the placebo. Also to note here, when the patients had higher dsDNA, the drug seemed to be better than when the patients had lower dsDNA, and patients with class 4 lupus showed better treatment outcomes when compared to the class 2 lupus cases. Previously diagnosed patients, as I said previously, 81% of the patients were previously diagnosed. Here we can see that the previously diagnosed cases or older cases had lesser response when compared to newly detected cases, and patients with lower GFR almost had maybe 5% difference in the on comparison. So to summarize the different things that we have seen, 2 years of obinutuzumab treatment was studied in patients with active lupus nephritis. Obinutuzumab 1000 mg plus the standard of care was given. The dosing was 2222 or 2221, and endpoints were measured and found that obinutuzumab group had a better treatment outcome. So safety of the drug. any adverse event during the therapy. There was 126% of adverse events in the obinutuzumab group, whereas 117 in the placebo group. Serious adverse effect was something that would be life-threatening, including a neutropenic sepsis or a reaction to the drug, which would be life-threatening, which is 44 in obinutuzumab group when compared to 24 in the placebo group. Deaths were three in number in the obinutuzumab group, wherein two were COVID-related deaths and one was severe neutropenia. Even in the placebo group, there was COVID-related death because this study was during the COVID era. There was a lot of COVID-related issues during the study. As you can see, serious adverse effects of more than 5 patients, seven in obinutuzumab group had COVID-19 pneumonia. Uh, Other pneumonia was the other infection that was causing problems in the obinutuzumab group. Other problems were UTIs and gastroenteritis. Uh, More than a grade 3 adverse effect, wherein it can be near life-threatening, was 44 in obinutuzumab group when compared to 22 in the placebo group. Infection, which is the major problem here in the drug, which is 98 percentage in the obinutuzumab group. Infusion-related reactions also were suspected. Infusion-related reactions was actually avoided in the study by giving a small dose of steroid prior to the infusion or along with an antihistamine. But some patients did develop some infusion-related reactions, some allergic reactions, which was managed, which really was not really fatal for the patient. Grade of greater than 3 infection was seen 21 in obinutuzumab group more when compared to the placebo, and most of these infections were related to neutropenia as well. Multifocal leukoencephalopathy also was mentioned in the protocol, but however, none of the patients in the study developed this problem. Drug-related neutropenia was 17 in the obinutuzumab group when compared to 5 in the placebo group. So discussion. So this trial confirmed the efficacy of an anti-CD20, which is type 2 anti-CD20, as a add-on therapy to the standard of care in lupus nephritis. The Regency trial previously demonstrated it, and now this showed much better benefit with the type 2 CD20. Peripheral B cell depletion, which is defined as CD19 counts of less than 10, was sustained in 95% of the patient till weeks 76. Much better than having 80% of the patients depleting at 52 with rituximab in the LUNA trial. So the anti-dsDNA antibody reduction and complement normalization was seen in this trial, which is actually a reflection of this B cell reduction and the cytotoxicities which is coming down. Uh, Long-lived plasma cells were found in circulation and kidney interstitium, which play a role in the renal flares were actually depleted by this obinutuzumab because of its stronger ability to deplete B cells. So that is the reason why this drug has been now studied for membranous nephropathy as well as ANCA-associated vasculitis and FSGS as well. Strengths of the study, it is a phase 3 trial and it's on a very rampant disease, so and showing some benefit. So it probably should be able to be applied to our population as well. Since there were multi-ethnic populations involved. Longer observation period also gives us better understanding about the safety of the drug. Limitations, however, there were no post-treatment biopsies done. So we do not know the inflammation status in the kidneys after the treatment was given. Mortality in obinutuzumab group was actually higher. Probably that is the COVID-19 pandemic which is going on, and that is the reason why it was mostly during the initial phases of COVID-19 that the deaths were reported. Neutropenia is there among patients. Around almost 17 to 18 patients had neutropenia, and that is also contributing to the higher infection risk during the period of infusion. Lesser representation of our population. Only 5.9% of the population was among the study were Asians. So we do not have much data about how the drug would behave with our population. KDIGO actually recommends usage of CNI belimumab and cyclophosphamide for induction as such, but there is no head-to-head comparison with this drug and the standard of care cyclophosphamide also. And the issue is the cyclophosphamide will work out to be much cheaper when compared to this drug. Uh, so the cost factor is also a factor in our population. To summarize, so type 2 B cell depleters are better than type 1, and they have found a very good role in depletion of B cells and reducing the antibody levels, and also to reduce the progression of lupus nephritis. Uh, Major concern with these drugs is the infection risk, and the pandemic that was going on also had probably contributed to the mortality during the study. Uh, we need some studies in our population as well with these drugs to see how they behave, and infusion related reactions and other neurological abnormalities that would have happened in our population when compared to the uh, population which was actually studied in this study will really not be known. Uh, we need to compare this drug with probably cyclophosphamide, which is being rampantly used now, and see if there is any benefit when compared to cyclophosphamide and the cost factor. Thank you.
Um, Thank you, Dr. Nitin. I think that was a very lucid, very good presentation, I guess. So we'll now request the panelists to give their opinion about the presentation and also about the journal per se, about the article. And then we'll start taking questions from the chat box and then take opinion from all the panelists. Dr. Manish Rathi sir and Dr. Mayuri ma'am.
Hi, Arun. Thanks. So, thanks, Nitin. That was a very lucid presentation. I agree with you about the limitations of the study that you said that, yeah, this study really does not have Indians being, I mean, Asians being represented to a very large numbers. The other point is that it probably excluded the severe disease. And I personally feel that, the kind of lupus patients we see, or, the patients which end up reaching the nephrology OPD usually have a GFR which is much lesser than what was included in this study. I don't know. I mean, I would want Manish also to kind of comment on that, because he's somebody who works exclusively with lupus. So definitely we see a much more severe disease, because if you see their main, if you see their mean GFRs, very less of our patients actually present to us. They present to us with a much more severe disease than that this thing is there. Also, they have given a lot of importance to proteinuria. But, the class of patients that they have said is in proliferative lupus nephritis. So again, would proteinuria be a good outcome measure? I am not too sure of that. I mean, probably concentrating more on the GFR would be important. And of course, infections is a major issue for us. So, with the severe reactions being so high and infections being so high, I think even I would question the utility of this drug in our settings till, a specific study that comes up with India and our population.
Thank you, ma'am. Dr. Manish Rathi sir. Yes.
Yeah, thanks, Arun. Thanks, Nitin, for presenting this journal club. So a few comments from my side, and then I'll share my personal experience also with use of this drug. So first few comments are that you have already highlighted less Asians, but it is fine. Like this is a multinational, so they have tried to kind of recruit all kinds of. So unless we have some study which is dedicated to Asian population, will not find too many Asians in these kind of a study, and that is by and large in all these kind, whether it is Voclo trial or Belimumab trial or whatever, unless we do our own study, there will be lacking of Asian population. We have to bear with that. Second point is, in fact, actually, it is slightly at odd what Mayuri has said. Actually, they have included severe patient, and that was very surprising actually, because if you see their exclusion criteria was GFR less than 30, so they have included till GFR of 30. Although the mean GFR is normal, but if you see the serum creatinine upper ranges, it is 3.75 in the OB group as well as 4 point something in the MMF group. Now, and that is why if you see that curve, diagram where they have shown that this drug was better in patients who had lower GFR less than 90, because you don't use MMF in this group of patients who have severe renal dysfunction. Here the comparator was MMF. So you don't use MMF in these kind of patient, and that is why actually the MMF efficacy was down. So that is why combination, yeah, this diagram, next one, the next one. Yeah, this one. So you see, if GFR is less than 90, the OB was better, much better than in GFR more than 90, because MMF is drug of choice in more than 90. It is not usually considered in less than 90, particularly if it is something like 30 or 40 GFR. Serum creatinine is around 4 or something. We usually don't give MMF. Nobody usually give. If we want to give, like we can give a low dose of cyclophosphamide, or if even if it is advanced renal failure, we'll give conventional cyclophosphamide. So that is one point which I think is very obvious, that they have used MMF in these kind of patients. Third thing which I would like to know is also the biopsy parameters, like what was the activity indices, chronicity indices, like how whether there were presence of crescents, because class 3 and 4 is also very heterogeneous kind of disease. You have variety of class 3 and 4, so we can't club. Although I am sure, because we had discussion with Dr. Brad, and they will come out with some post hoc analysis, and they will give some biopsy details also, like, and then we will come to know. Finally, just like this, the same group of researchers have done with Bliss LN, they have done with this, that when directly you can't prove something, you have to twist. So what twist was done in Bliss LN is they came up with a new parameter, which is PERR, that is primary efficacy renal response, because they were not directly able to show. And similarly, in this paper, they have come out with the response rate with serum with a Vicelone dose of 7.5. So how many patients were able to maintain their response even with lower doses of Vicelone? That is how they are pushing this drug. I'm all in favor of using this drug, but what I'm trying to say is that we have to be aware of all these limitations whenever we are analyzing any paper. It's not just straightforward that we just look at primary response and we look at the p-value and then we go all gung-ho about this drug, right? So these were few points, I think, from my side, and then experience, our personal experience. So this drug is available in India. So the cost of therapy, conventionally, this is available with Roche, and the cost of therapy is 4 lakh for 4 injection. But if you talk to them, they will reduce with their patient support program to something around 2.5 to 3 lakh, or maybe around 2 lakh, whatever. This depend on your center and their mutual relations. So we have given this in 3 patients. So all these 3 patients were refractory. So unlike in this trial and Nobility trial where this drug was used upfront as first-line therapy, we have never used this drug as first-line therapy. So all these 3 patients were refractory patients who have not responded to cyclophosphamide, to mycophenolate, as well as to multi-target therapy, right? We have not given rituximab because our experience with rituximab is not good. So we gave this obinutuzumab, and all 3 patients have shown complete response. So this is a wonderful drug. The best thing with this drug is this causes complete and sustained depletion of B cells, CD19 cells for a longer period of time, but maximum up to 1 year. And that is why when Nobility came, we started using this drug, and then we gave 2 in the beginning and 2 at the end of 6 months, because that was the dose which was used in Nobility. And then we have not repeated after 6 months later on. And all these patients at the end of 1 year had shown a comeback of CD19 cells with increase in proteinuria. None of these patients required any treatment with obinutuzumab. So 2 patients have been sustained in kind of response with MMF. One is with MMF and steroid maintenance therapy, and second patient is with the tacrolimus, low dose tacrolimus along with MMF and steroid. So we have not used. The third patient actually have developed complete remission, but subsequently had developed COVID-19 infection, and then followed by CMV infection, and then that patient died. So again, in our circumstances, when we are using so many immunosuppression and our patients, are our environment is also infection friendly, I would say. So our patient is more prone to develop infection, and that is what they have in discussion also. They have said that you have to be very, very cautious about infection. You have to vaccinate. You have to complete the vaccination, specifically the COVID vaccine and any other vaccine which these patients may require. So complete the vaccination and be very careful of infection with this drug, because in addition to OB, you are also giving other like steroids and MMF. So yeah, limited experience, just 3 patients, but this is what all sustained complete remission, one died of infection, and 2 are maintaining remission. And we have given 4 doses, 2 in the beginning and 2 at the end of 6 months. We have not repeated what they have done now in the Regency.
So Manish, you would, whatever, with the limited experience, but I'm sure that's a good experience, at least for India. Would you still say that this is a good rescue therapy, especially for patients not responding to the conventional therapy?
Definitely, yes. So I am all for this drug, particularly if you are itching to use rituximab, you should use this drug. Don't use, because somehow they some rheumatologists are in the favor of I think most of nephrologists agree that rituximab is not a good drug
Doesn't,
for
yes.
lupus, but somehow some rheumatologists are giving rituximab and giving it as a first line therapy also, with good according to them a good response, but not a published kind of this thing. But what in our experience, we have used rituximab in around 15 patients initially, and only one developed partial remission, and remaining all of had and all these were refractory, like they were not the first line therapy. So then we stopped using rituximab, and then when these 3 patients came, and these 3 patients were like who were either affording or had reimbursement, so we were able to give obinutuzumab. So if you have option, or wherever you think that you want to give rituximab, I think in place of rituximab, this drug is much better. This causes much sustained depletion, not only in the circulation, but also in the storage, the reticuloendothelial cells, in the lymphocytes, so that CD19 does not come back quickly. And that is the main problem with the rituximab. But again, the pathogenesis wise, if we go further, targeting B cell therapy alone is not going to work for a longer period of time. So now people are looking into combination kind of therapy with the BAF as well as BAF inhibitors and CD19, because with CD19 the BAF is over activated, and and just with Bliss kind of therapy, Belimumab kind of therapy, CD19 is not. So what we require is combination, and there are certain drugs. So one is combination of Belimumab and rituximab, or Belimumab and obinutuzumab. In addition to that, there are certain drugs which act on both the pathways. One single drug acts on both the pathways, and there are studies which are going on, and we are also part of that study. So because of non-disclosure agreement, I am not revealing the name, but there are drugs like which are targeting both the pathways simultaneously. So we are also studying these drugs, and I think this will be the future, where you are targeting both the pathways and then depleting, causing a sustained depletion. Obviously, when we are targeting both the pathways, we are also have to be aware about infections.
So thanks, Dr. Manish. So in addition to use of this drug in treatment refractory to the standard treatment that we give, so do you think that after the publication of these results, that there might be a role for this drug in our patients who are otherwise not, with respect to the GFR, their GFR is not very low, maybe somewhere more than like 50, 45 or 50, they're like between 45 to 90, and they are on, like, let's say MMF and steroids, but they still have significant proteinuria. I do understand that one of the things that we would usually do in clinical practice is maybe do a repeat kidney biopsy to check whether the disease is still active, or we are dealing with a scarred or we are dealing with scarred glomeruli. But in case we do decide to do a kidney biopsy and find some degree of activity, so would that group also be eligible for this drug in our settings?
So, as I've said, we have not used as a first-line drug, and I don't think that we will be required to use it as a first-line drug. Why? Because if you compare publications from India, from whatever center you take, from South, you take from East, Dr. Arpita Center, you take South, Dr. Manisha Sai Center, you take our center, you take any other study, and you compare the response rate with the Western, our response rate are always good as compared to, so our response rate, if we combine complete as well as partial response, our response rate are in the tune of almost 80%, 80 to 85%, as compared to Western, where they have at the best reached 50%, like 30 to 50%. So our patient by and large responds very well with whatever treatment we are giving. So we are left with 10 to 20% of cases only at the best. So as first line therapy, I don't think we will have to use this drug. But as I've said earlier, some people are using, specifically rheumatologists are using rituximab as first line drug because of variety of reasons, because these are young females, or we are afraid of side effects, or whatever are the reasons. But whatever we are doing currently, we are able to take care of almost 70 to 80% of cases. So remaining 20 to 30% of cases we are left with. So the next line of therapy, suppose they are only proteinuric and normal renal function and mild activity or moderate activity, the next best drug I think would be combining something like CNI with mycophenolate mofetil, followed by urolupus regimen. And the NIH should be limited. And at our center at PGI, like NIH is now restricted to less than 10% of cases. With what, like we used to say that we are getting very severe cases, whatever, but now with all these kind of available treatment, NIH is now restricted to less than 10% of cases. So vast majority of these patients will not require. But as I have said, there will be some patients like we have seen who will not respond even to your cyclophosphamide, and then you will have to use, because you don't have availability of belimumab and obinutuzumab is available, you can very well use. But I think as first line therapy, still we have to wait for long term data.
So what
If
Manish, you said,
question.
the one thing I just wanted to ask, you said that NIH means cyclophosphamide in less than 10%, but in severe cases you don't use MMF. So means what is your, if the patient come with a GFR of 30 or 40, would you not use MMF or use NIH? What is
So now our NIH is restricted only to dialysis requiring renal failure and severe neural
that?
psychiatric, or this is the only group where it is restricted.
So
So yeah, in other kind of cases, suppose we have low GFR but they are not dialysis requiring, what we are doing is urolupus regimen. And actually, if you see urolupus regimen, where we give fixed doses of 500 milligram, and if you do modification as per the GFR, actually it comes to the normal dose only. We
normal dose,
call it we call it as a low dose, but actually it works as a high dose, normal dose, and we give it more frequently also, like every 15 days, and it works very well.
so basically, so is there any threshold of GFR below which you will not give MMF? Because we usually, if the patients, is there any head-to-head comparison where, except for very severe lupus, you will give NIH regimen or cyclophosphamide if the GFR is?
Yeah, so GFR usually we don't give like serum creatinine of 4 and above. So
Yes.
you can say GFR something like 45 mils or something like 30 mils. We don't give MMF. If we have to give, we will either give urolupus or we'll give. Yeah, but there is some evidence. I think there was one publication from Hyderabad where they have actually used mycophenolate mofetil in severe cases also. Some of those were dialysis requiring also, but it is a small study where they have shown comparable results with the NIH regimen. So there is some, and that is why some people do give mycophenolate mofetil, but we are not very confident in using mycophenolate mofetil in severe cases. So in those cases, we'll use either ELNT or NIH, or we can also consider, suppose patient is not willing for this thing and you have given MMF not responding, you can add on something like TAC, or you can try this drug.
Yeah, Manish, I think I would second you on that. Even the word that you used was right for me, that not confident to use MMF if the GFR is less than 40. I think it's more of comfort, or just, I don't know whether it's a mental thing, but yeah, if the GFR is less than 40, using it would always automatically the choice would be a Urolupus or whatever the GFR corrected dose of endoxa.
Yeah, I think almost all of us would agree with that. And considering that the amount of adverse events, I think, which is usually we're afraid of, doesn't happen with cyclophosphamide. I think our population usually tends to accept it better. So I think that is another reason which I
And
would
another thing,
probably think that
like
for
very Arun, very worrisome, which was always there in our mind was, ovarian toxicity. So ovarian toxicity usually, and specifically the irreversible ovarian toxicity, usually don't occur with kind of doses. And if you are in some private center and if you want some evidence that will support your uses of cyclophosphamide, actually there is publication from our center where we have studied ovarian functions, the follicular count as well as hormonal profile, and we found none of the cyclophosphamide patient had irreversible ovarian failure. There were 2 or 3 patients who had reversible ovarian failure, which again came back to the normal, and one had irreversible, but in that one patient the age was around 45. So this patient was something like perimenopausal kind of thing. So we think that this irreversible is basically because of perimenopausal. And we all must have seen in our clinical practice wherever we have used cyclophosphamide that usually some degree of reversible may be there, but like the kind of doses we use these days, the irreversible ovarian failure is almost negligible.
do you use GnRH
No,
agonist regularly with the cyclophosphamide, sir?
no.
Fine. I think we have a couple of questions if we can just rush through them from the chat box. One was about the target of CD19 which we use. Is it less than 10 or 5 per 5 cells per microliter? Because this study had used 10 specifically, and whether 5 is what is standardly used.
So actually, we don't we check CD19, but we don't usually target CD19 because we are giving fixed doses. And here also, irrespective of CD19, they have given fixed doses. So, and even if you go by the experience of ANCA vasculitis, where they have targeted CD19 rituximab according to CD19, they have ultimately said that it is not useful. It's better to keep on giving whatever you are giving, irrespective of CD19. So why we check CD19? So somebody should not have something like 0 or 0.1 and you are still giving, you may wait for another 2-3 weeks so that it comes back. That is the only purpose of doing CD19, but we are not targeting. Even in ANCA vasculitis, now the targeted CD19 use of rituximab is now outdated. They do use fixed doses.
I think one other pertinent question was whether we really need a biopsy to document histological remission before we stop therapy or to confirm clinical remission. Do any of your centers follow a repeat biopsy before cessation of drug therapy or to confirm complete remission?
So actually, we are not following that thing, but I can't say it on a public forum that you should not be doing it because we have literature evidence to support it. So if you are comfortable in doing that thing, if your patient is agreeing in getting it done, then it is best to get it done and then before stopping. But personally, we are not doing that because of variety of reasons.
How about you, Dr. Mayuri, ma'am?
No, so if I'm able to convince the patient, and I would prefer doing it, doing a protocol biopsy and then stopping the immunosuppression. But most commonly, the reason where we are not able to do it is because the patient does not agree, or the cost of the biopsy is an issue.
Yeah, perfect. I think that is what most of us would follow. The next question was whether is there a possibility of combining MMF and cyclophosphamide, a low dose MF with a urolupus regimen as induction therapy.
Why would you want to do that?
No, I think this is an whosoever has asked this question, I think this is a good research question,
Considering
I
that
would say,
urolupus,
and certainly should be. Yeah, certainly we can study, we can do, pilot kind of a study to begin with, because then you will be reducing the doses of both the things. So you will be using lesser doses of cyclophosphamide and lesser doses of mycophenolate mofetil. But having said that, this is a good research question, you also have to be worried about the side effects, because both are bone marrow suppressant, anti-proliferative kind of drugs. So you have to be worried about the side effects also. But nobody has used, I would say, I am not aware of any combination of this kind.
I personally would be very scared to use them, as Manish
I
said.
think there is some data on cyclophosphamide and tacrolimus.
No, I think Dr. Arpita has used tacrolimus and azoran. That was also a wonderful combination actually, because to reduce the cost of therapy, and they have shown that they had equivalent results as compared to TAC MMF. So TAC AZA combination is another thing which we can, if our patient has affordability issue.
Also, I think there was one study which was published a couple of years back where they combined cyclophosphamide with tacrolimus for induction also, which also had very good response without any increase in infections. I think, but that was only one study. So I think
No,
all
but
these, I think, have got.
whenever we say that they had good response rate, we always have to compare it with cyclophosphamide alone, because cyclophosphamide as such is a very good drug. So unless you do an head-to-head comparison, you will not be able to say what is the effect of cyclophosphamide and how much is the effect of tacrolimus in this combination, because alone cyclophosphamide itself will cause very good results. It will cause almost 80 to 90% response rate in our patient group.
Considering the word head to head, I would like to know if obinutuzumab, how will you rate it as against belimumab or voclosporin in the ideal scenario where all three are available?
Mayuri?
I don't know. I would kind of. I don't have a personal experience with any of these drugs, but I don't know. I really don't know. I mean, cost.
No,
So
overall with
yeah,
regard to benefit.
all these are costly. So cost, I think, will come down to, because there are now Indian companies who are planning to launch Voclo at least, and Belly also they are trying to. But if you go academically, like based on the scientific evidence which we have, if you have a proteinuric patient without any significant renal dysfunction, without significant proliferation, it is predominantly class 5, and there are no multiple relapses like these kind of patient profile is there, it is better to use CNIs, which also include voclosporin. But if you on other end you have a patient who has multiple flares, who have predominantly proliferative lesions, who have some proteinuria like non-nephrotic range proteinuria, but also has some renal dysfunction, then it's better to use either belimumab or obinutuzumab, because we don't have any head-to-head comparison. And as we have discussed in the pathogenesis, I think that in very near future, it will not take 10-15 years. In next 2 or 3 years we'll come out with data that these drugs will be outdated, and you will be coming up with a drug which is targeting outdated means like we will not be using them alone, either we'll be using them in combination, because if you go by pathogenesis, you have to target both the arms of the pathogenesis, that is BAF as well as CD19, and some drugs are coming up with this. So I think in future this treatment regimen is going to be changed again, where we will have more availability of drugs which will be targeting these pathways.
And I think we'll just have a quick review of the questions. One is about immunoglobulin profiling, whether it will help us prevent infections, and if hypogammaglobulinemia is more common with obinutuzumab. I think we don't have much data for it. I think we don't have data for both immunoglobulin profiling or the extent of hypogammaglobulinemia with obinutuzumab. But sir, ma'am, anyone?
No. Hypogammaglobulinemia, you have to be aware of, especially we have data in ANCA vasculitis with rituximab maintenance, that you should check hypogammaglobulinemia, and if hypogammaglobulinemia is there, you should replace it with IVIG or delay the dose of rituximab. That is there. So hypogammaglobulinemia do occur with these drugs, and I'm sure it will occur with obinutuzumab also. The thing here is that obinutuzumab is not used for a longer period of time. So as we gain experience and as longer duration evolves with use of these drugs, we'll get all the answers of these kind of questions.
And the last question is about upfront multi-target therapy. So
Yeah, I think
how
that
do
is
you
what
see that in your
Dr.
practice?
That's what we just discussed. That's exactly
Discussed.
discussing. Yes.
Yeah.
Fine. So I think we've discussed we have discussed all the questions, and I guess you will agree that we have learned a lot from our panelists and a wonderful presentation by Dr. Nitin. Thank you, Dr. Manish Rathi sir, Dr. Mayuri ma'am, and Dr. Nitin for the presentation. And we'll call it a day for today, and hope to see you all in the next month's JC by the Indian Society of Nephrology. Thank you all. Thank you.
Thank you.